Bismillahirrahmanirrahim. My name is Dr. Atta Waqar. I'm ophthalmology resident at National Medical University and Hospital. Today I have a case for you. A 27-year-old gentleman presented to OPD with unilateral left droopy lid since birth. His vision in both eyes are 6/6 with -5 diopter spectacles. Extraocular movement are normal and fundi are normal. Please guess about your diagnosis. This is the pre-op clinical image. In the pre-op clinical image at left eye, you can appreciate that he's using glasses and there is droopy lid at the left eye. This is also a pre-op clinical image in which you can appreciate that there is Blepharoptosis or droopy lid, and you can appreciate that there is a semicircle bumpy area. Please guess what will be this. With this arrow I have shown to you. So let me to give you the past ocular history of the patients. Patient he is using in both eyes -5 diopter spectacle, and also he has done 4 years back left eye frontalis sling procedures, and that was not buried completely, and some dispenser he has removed the suture and cut the suture, and that failed. So there is no history of trauma and no history of medication, intravitreal injection, laser in this patient. So his vision in both eye with spectacle is 6/6. Extraocular movement is full on in gaze with non-astigmus. Marcus gun was negative. Anterior chamber angle on one Herrick, that was grade 3, and he is bilaterally phakic. On applanation tonometry, his bilateral intraocular pressure is 11 mm mercury. On fundus examination, his bilateral foveolar reflex was present, and disc was 0.2 to 0.3 bilaterally. On systemic history, that was unremarkable. There is no diabetes mellitus, hypertension, ischemic heart disease, asthma, or rheumatoid arthritis. So before going to operation, we are going to do certain measurement for Ptosis evaluation, and this is a checklist. This is a very good acronym, and you can remember very easily. For example, we have to do this in all patients, and we have to evaluate very carefully. For example, M stands for measurement in mydriasis. We have to find in both eye if there is pupil is dilated or not dilated. Eyelid closures like Bell's phenomena we have to do, because if we are doing a very good procedure but there is Bell's phenomena is not good, that can lead to corneal dryness. Abnormal external examination, skin crease is stand for skin crease, because that can show us that it is a congenital or acquired. Up position of left R stands for reflex, or like Hirschberg test we are doing, that patient don't have any kind of strabismus. E stands for error in vision or refraction we have to do in all patients, because severe ptosis can lead to amblyopia. And myasthenia gravis we have to rule out, because that can lead to at the evening time the patient will have ptosis, or that will be most commonly bilaterally. In evaluation of history, and we have to ask from the patient it is congenital or acquired. And also decrease innervation, any kind of extraocular movement, if there is fourth nerve, sixth nerve, or third nerve palsy, we have to rule out that. And we have to do slit lamp examination to evaluate the tear film. So in checklist we have certain items that we will not forget. You know that palpebral fissure height is the distance between the upper lid margin and lower lid margin at the center of the pupil. So and we have MRD1. MRD1 is the distance between the corneal light reflex and the upper eyelid margin in primary case. So you know that our upper lid cover the 2 mm of the cornea. It is normal. But what is the MRD2? MRD2 is the distance between the corneal light reflex and the lower eyelid margin in primary case. Actually, the MRD2 is larger than MRD1 in normal person. So in our patient, the checklist for ptosis evaluation, I have mentioned previously, palpebral fissure height at right eye was 10, at left eye it was 5, MRD1 at right eye was 4, MRD2 was 6, MRD1 at left eye, that was -1. Why I am saying -1, I will show you later. And MRD2 is 5. Levator palpebrae superioris function at right eye was 15, at left eye was 4, and bilateral Bell's phenomena was good, and there was no jaw winking in both eye, in both upper lid. So I have said that why I have said -1. So you know that I have mentioned that normally our upper eyelid, it covers the 2 millimeter of our cornea. So it is normal, but if the lid is coming toward center of the pupil, so it increasing in the severity of the ptosis. For example, if the ptosis is coming at the left side, you can appreciate that 0, 2, 1, 3, 4. Okay, if it covers completely toward 5, so that is severe ptosis, and the patient will, there will be severe amblyopia in this case if the completely the pupil is covered. So according to that, at right side there is MRD1. So we have said that MRD1 is actually the distance between the corneal light reflex and the upper lid margin. So if the upper lid margin is at just above the upper at the pupil of the pupil margins at 12 o'clock, around 12 o'clock near, so that is 2 millimeter. MRD1 is 2 millimeter. If it is coming, this upper lid is coming toward center, then going near to that at the lower border of the pupil, so we are saying it is -2. If that is more inferior to that, is -3. So it means if we just for example with our thumb we are elevating the lid. If I have elevated the lid, so I have appreciated the corneal light reflex, and I measure that area, it is called -3. So in our patient it was -2, -1, sorry. So in this you can appreciate that what is -3, the upper lid margin, just the black one, that was previously at -3. I have if I elevate the upper lid margin with thumb, so I appreciate the corneal light reflex, which is showing in the white, so it is -3. This is management plan. We are coming normal MRD. If the ptosis is mild ptosis 2 millimeter, MRD1, MRD2 3 millimeter, 4 millimeter, 4 millimeter in severe ptosis we have. So we are using different kind of material in this patients. We can use for severe ptosis autogenous fascial Atta, and we can find that from the patient own and also from the bank, which is not easily available, and polypropylene Prolene suture, which is easily available in market, and also silicone rod we can use. So diagnosis in our patient is left eye severe blepharoptosis, and we are doing this under local anesthesia with Prolene 20 straight needle. I will show the images of this. This is the image, and we use these items in our operations. You can appreciate here that 2O Prolene suture with a straight needle that is masked, and we are using OVD with lead guard just to avoid the injury of the cornea. And also we are using 15 number blade for stab incision, and also after 1 week we will use Waqar 60 to close the incision site. So this is after local anesthesia, after full aseptic measurement. I have given for anesthesia combination of injection lignocaine and bupicaine with adrenaline to avoid bleeding, and hemostasis will be good. And I have changed the 5 with 5 ml syringe. I have changed the needle of that with 27 gauge needle, and I have just palpated the superior at the superior border supraorbital notch. I have injected there, and the patient was there was no pain, and because patient had previous experience also, and he said that there was less pain or no pain. I have not find any kind of difficulty. And also I have injected around the pupil, around the upper lid margin. So let me to show you the procedures. This is the marking of pentagon, and we are making a pentagon, two incision at the lead margin 3 millimeter above, and you have to, there should be a lead guard also with the, and you have to instill in the eye topical anesthetic. Then around on the cornea you have to put gel or OVD, and you have to save the globe, and you have to give 2 incision there around the 3 millimeter above, and 2 incision just above the eyebrow, and 1 incision at the center of the pupil, just at the center of the pupil, and you have to give a stab incision, and this is the marking you have to do, and then you will give stab incision, because later you will not find that. So let me to show you the procedure. You can appreciate I'm passing the needle from the upper lid. So there is good hemostasis and no bleeding.
Bro suspension.
And when you are passing here, so this is a very critical stage, and which
we are passing here. This is critical stage.
Because if you have to invert the lid, because if you don't invert, that can
removing this needle
lead to corneal. That can lead to corneal irritations in the eye. You can appreciate here very well. Before passing,
I have given
you have to appreciate this and confirm. So we have completed our procedures in which we have just given a temporary knots to the proline 20 because there is edema, and after 1 week we will reevaluate that. This is the post-op image of the patient, and I have applied inferior lid cell 40 suture to avoid immediate corneal dryness, because there is a dressing, and we are removing after 24 hours. That if there is corneal dryness, it is not good. To avoid that, we are applying 4/0 silk sutures. And you can appreciate here, after removing that 1 sutures, patient has improved very well, but it need adjustment. So we are giving time to improve the edema, and after that we are evaluating the patient. And I have asked the patient to close his both eyes, and Bell phenomena was good, and we had evaluated that previously before operations. So there is no corneal dryness or no corneal show. Post-op image of the patient, in which we can appreciate there is a little bit asymmetry, but we can readjust that. Patient was a bank manager, and I have asked to send me regular images, and you can appreciate at the upper lid there is a edema, and also I have asked that during sleep you have to send me pictures, because if there is a severe corneal dryness, if there is a corneal dryness, we will undercorrect this, but that was good. And this is the post-op image after readjustment, and we have done the readjustment and buried the proline 20 suture, and closing the incision site with Waqar 60 after 1 week. And you can appreciate at both eyes, and there is very good symmetry, and patient was so happy. So this is a very satisfied patient post-operatively, and he was so happy from the procedure. And this is also post-op image. You can appreciate the symmetry in both eyes, and aesthetically it is so acceptable for the patient. This is also a post-operative picture of the patient, and patient was very happy. Thank you from your time and attention.